and we will be with you shortly whilst we've given everyone a chance to join today. I hope the weather is good wherever you are, and it's different in different parts of the country. So as I say, we'll just wait a few, we've got people coming in still, so if we'll just wait another minute or two and let people join, if that's okay. This is normally the bit in the meeting where we all say hi and mingle and hang our coats up and, you know, get a glass of water or whatever it is, I think. So thank you for joining us. Here we go. So it's been a busy day, I'm sure, for everybody. I don't know if anyone, this is like really boring for most people, though we've had this real problem with Instagram. Instagram blocked our account, they blocked endometriosis hashtags and Endometriosis UK, which Faye, our comms manager, has been trying to sort out, which is somewhat annoying, trying to get hold of people. But thanks to, in fact, some behind the scenes work from some journalists, they did get in touch and they've unblocked that, but it's been a bit frustrating. So if any of you have sent us stuff and we've not posted it and things like that, I do apologise for that. Now, we've got a good number of members who've joined us now. So what I think we'll do is, if we kick off, there might be some people joining. I just need to do a little bit of housekeeping, which is to say that we are recording this. So if people want to see it afterwards, that's great. Could I ask, please, that if you've got questions, that you put them in the Q&A function at the bottom. So not the cat chat, the Q&A. That makes it much easier for us to see them and answer them, and also to collect them afterwards, so we can make sure we keep a record, etc. So if you could please stick to the Q&A, I'd be really grateful on that one. The other thing I should say, that should you need it, there is a live transcript available. You should be able to click on that if you want subtitles for this. Anyway, so housekeeping over. Welcome everyone to the event this evening. We're delighted to be working with FTWW, Fair Treatment for Women in Wales, and Fertility Network UK, along with Endometriosis UK, to bring you this event this evening. And what we're going to be talking about is the future of endometriosis care in Wales. We had hoped that Ruth Jones would be with us. She's unfortunately been called away on important Senate business and sent her apologies, but we'll be watching this afterwards, so we'll make sure that she'll get information. And we have with us as well, excuse me, Jenny Rathbone, member of the Senate. We have Richard Penketh, who is one of the, I'd say, the lead endometriosis consultant in Wales. Liz, who many of you will know, Liz Bruen, who's the specialist nurse. We have Connolly, who is the endometriosis, the women's health lead for the RCOG in the UK, and also joined by Anna and Gemma, who will be sharing their stories with us as well. So what I was just going to do is a very quick introduction before handing over to Jenny. So I should say, because I haven't probably, my name's Emma, I'm Chief Executive at Endometriosis UK. Delighted to be here, and massive thank you to FTWW and Fertility Network UK for working with us on this and many other projects as well. One of the things that's interesting about talking in Wales is that I think we're all aware that there's some real issues to do with the geography of Wales and access to specialist care. We also know that the unfortunately, the length of diagnosis time is the average length of diagnosis time is longer in Wales than the rest of the UK. So the UK is on average 8 years. In Wales, that's on average 9 years. I think we all feel that that time is shocking. And I think one of the things that we're really keen, and I know again working with FTWW and others, is to really make sure that we focus on that and try and drive down diagnosis time. You know, my target would be, and we're asking the government to say by 2030 it should be an average of a year or less going forward. And I think as we and Richard will be talking to us about how things are working in the NHS at the moment, we all know things are a real challenge because of COVID. But we also know that before COVID, there was that 9-year average waiting time. We also know that 60%, almost 60% of people getting a diagnosis would be going to their GP 10 or more times with symptoms, and to hospital 5 or more times. A&E, we know that almost 50% go at least once, and 21% go 3 or more times to A&E as well. So what I'm hoping that by working all together, what we can try and do is streamline the processes going forward, so we get better treatment and diagnosis times, but also help the NHS when it's struggling with all the volume of work. I think the other areas that we're keen to work on, the diagnosis time is also due to the length of diagnosis, is people quite often don't recognise their symptoms, or more to the point, they're told that their symptoms are normal, or they're being a wuss, or they've got, you know, a low pain threshold and they should just get on with it. And I think that, so one of the things that we're really pushing, again working with FTWW, is around trying to get menstrual wellbeing included in the school curriculum in Wales, and that has been agreed in England, but it has not yet been in Wales. And as you might be aware, that we've been doing a lot of campaigning on that, and there is going to, whilst it's not in the curriculum, it is going to be in the RSE work. I always get those initials, they can be slightly the wrong way around. I can't remember if it's SRE or RSE, but there will be in relationship guidance something on that as well. So we look forward to working with Jenny and others to make sure that that goes forward. And of course, as I say, unless people seek help and know the right words and know that what they're experiencing isn't normal, then they're not going to help they're not going to be able to access help. Anyway, enough of me talking. I would like to again say welcome to everybody and hand over to Jenny, who's going to talk to us for a moment. Thank you, Jenny.
Hi, good evening. I'm Jenny Rathbone. I chair the Women's Health Cross-Party Group in the Welsh Parliament. Very pleased to join you. Normally we'd have all been marching around Cardiff making a big noise, but that's not possible this year. So I would like to just update Emma Cox, because the menstrual wellbeing is going to be a compulsory part of the relationships and sexuality education, which in itself is going to be a compulsory element of the education of all pupils. So there isn't going to be any opt-out, which previously existed. The Education Minister is absolutely clear on this. And in the last stages of the curriculum bill, which has now gone through the Parliament, she cast down assurances that this would be a compulsory part of the relationship and sexuality education. And obviously that's really, really important, because we need to ensure that boys and girls know just how challenging endometriosis can be, and understand that if somebody is suffering with their menstrual periods, it may not be normal, and they may need to seek help. So I know that a lot of work's been done in this Parliament with the Women's Health Implementation Group, and many of you, the people who are involved in that, are involved in this round table. So I'm very much looking forward into hearing what the outcome have been of all your deliberations, because I can tell you that there is no member of the Senate who does not know about this now, because we had a very powerful debate about this back in November, I think, and one of our members, Susie Davis, gave a really, really dramatic account of just what having endometriosis involved, and she previously hadn't talked about it, so I think some of them were quite shocked. So I'm sure that we will continue on this work and trying to ensure that the way we fund our services is improved, to ensure that the whole of Wales has access to specialist services as required. I don't know who I'm handing over to.
You're handing over to me, and I'm on mute.
Okay.
Sorry, I'm doing what I normally do and forget to go off mute. Jenny, thank you so much. I'm delighted to be corrected by that. So thank you on that one. That's such good news to hear. And thank you for your words. I'd like to now hand over to Richard Penketh, who I'm sure many of you will know. And Richard is going to talk to us just for a few minutes about what's happening in services at the moment. Thank you, Richard.
Hi, welcome everybody. You probably know the history very well. FTWW wrote a very, very good letter to Andrew Goodall with lots of references about how things weren't so good in Wales. The response was very swift, and a working group was set up, which we arranged to be very multidisciplinary and inclusive. And we put in a report in April 2018, and the response of Welsh Government was to set up a women's health implementation group. That was to cover 3 reports. And the one that grabbed the attention first was the problems of MESH. Endometriosis, as you know, affects at least 10% of the population, and problems with MESH and prolapse, a few very vocal people who've been harmed by the MESH, but the MESH took over and became the core issue for the first year of the Women's Health Implementation Group. And then endo began to surface a little bit, and various initiatives happened. And the best of the first of those that's really coming to the fruition at the moment was that it was agreed that each health board should have an endometriosis nurse who would be covering primary and secondary care. This is not exactly the same as my dear friend Liz Bruen, who is a tertiary care, primary care and secondary care endometriosis nurse practitioner, but it's designed for the rural areas of Wales and the conurbations that don't have an endometriosis centre. And indeed, we're going to have one of these in Cardiff too, but it is not exactly analogous to Lizzie's role. It's a role to go out into the community and to work with what we hope will be a gynaecologist with a special interest in endometriosis in secondary care in each health board, and that will probably have more than one. And I think North Wales have done a really fantastic job. They've taken the nuts and bolts of the report, they've ignored the delays of the Women's Health Implementation Group, and they've set up their own working parties, and they've really moved forward it very, very well under the guidance of Geeta Kumar, who's been was on our task and finish group, but she's really taken that and moved very well with it in North Wales. Now, there's 2 other developments. I can't say too much, but there's been working with a commissioned organisation who has involved teenagers and younger children in developing resources for education about period health and pelvic pain, endometriosis problems in schools. So after the election, we are told that there will be a launch of this document, website, educational resource about period health, and I've seen it, and it's absolutely fantastic and really world-beating. It should be cloned and sold to England. It's really that good. So I'm really excited about that. The other thing that has happened is there's been a lot of work on a website. One of the people who was on the task and finish group was Jackie Boivin. She's a psychologist at Cardiff University, and she's been involved in developing this website work. And Liz and I had a meeting only last Friday, was it, about how it's progressing. That's going to be launched soon, and it's going to have in it, they're not trying to reinvent the wheel, but there's going to be questionnaires that allow women to log their symptoms, return and log them again and again and again and again, and generate some kind of graph that they can then take to their GP. Now, Liz and I have said, you know, that's phase 1, but you really need it to be able to be transmitted to the GP directly by pressing a button. And you need to have individual accounts that you can revisit rather than having to log yourself in every time. So the first phase of this is hopefully going to go live in the next 3 or 4 months. But it's phase 1, and more money is going to be needed, Jenny, to drive it forward a bit further. It needs to integrate with the Welsh NHS IT system to be able to pass information from that website directly to the GP without the person who's put their information in having to then download it, print it out, take it into the GP, you know, in that sort of way. It needs to be more efficient and smart. What we've also been doing in Cardiff and Vale, we've been working with an organisation from Canterbury in New Zealand to do some pathway stuff. And there is a primary care endometriosis pathway that uses the NICE pathway and should help GPs to be able to be even more efficient. The problem, as I see it, is that there are a lot of extremely well-educated, efficient GPs, and we're getting a heck of a lot more letters in the last year or two that say, this 21-year-old girl has had this, this, and this problem. I wonder if she has endometriosis. Please, will you see her and sort her out? But there are lots of other GPs who need to be brought up to speed. And by having this pathway available, it should help speed things up. Now, the Endometriosis Task and Finish group has a new chair, Carol Schillebeer. She's a nurse by background. She's very dynamic. I had an hour's meeting with her a couple of weeks ago on the telephone, and she is extremely clear that she wants to design the best possible endometriosis service for Wales, define what that looks like, and then get it properly commissioned. Because one of the problems we've got is, unlike England, where do complex operation, money comes, money doesn't come. And one of the problems with complex endometriosis surgery is that there is no incentive for my hospital to do the operation. The way the money works in Wales is on historic block contracts. So the way I usually illustrate this is an unfortunate lady from Cardiff who's on holiday in Tenby has a miscarriage. She needs a 15-minute evacuation operation, which is an operation, and that's balanced by somebody from West Wales who needs a whole day in theatre with myself, a colorectal surgeon, a urologist, and that's one operation. So money doesn't flow, and sorting the funding out is a serious problem. Carol Schillebeer is very clear that the Welsh Health Specialist Services Commissioning is going to be approached to get this sorted and properly funded. So I'll be retired before this happens, but hopefully my successors will be in a place to take this forward in a really positive way. And I use the term that endo is seen as a thorn in the side of the Department of Obs and Gynae. And I think that's a realistic term because it costs without bringing any resource, and it fills up a lot of operating. We've worked out that even with the capacity that we had before COVID, we've probably got at least 5 years of catch up to do. In that it will fill our operating for 5 years. So we need a real visionary way forward. We've trained an extremely good colleague who's now in a locum consultant post, but there was a meeting between my two colleagues, Lutfi Shamsuddin, Tony Griffiths, and Nigel Davis, our clinical director, yesterday, and we've put papers in to support that I should be replaced, but it's not by any means guaranteed at the moment that I'll be replaced with somebody who can do endometriosis. They might want an obstetrician instead, and they might want a gynecologist who does prolapse as the priority. It's at the moment ill-defined and unclear. So any lobbying that can be done would be gratefully received. Anything else that I want to say? I think I've covered the bulk of it. Has anybody got any issues that they want to raise at this point?
We'll do that. We'll go on to questions when everyone's spoken, Richard. So thank you very much for doing that. And I think what's great to hear is what is going on behind the scenes, and certainly from the task of the Women's Health Implementation Task and Finish group. I know that what you've designed there is better than the NICE guidelines, and if that's implemented, that would be really helpful for people. And it's great to hear about the specialist nurses in primary and secondary care in those rural areas, and starting to get support to people who find it difficult to access things. So there will be some questions. There are already some questions for you, so I will come back to you if I may. But if we just carry on with introductions, so I'm going to ask Anne Connolly to just say a few words. So Anne, delighted that you could be with us today. Anne leads the Women's Health agenda for the Royal College of GPs, and is a GP based up in Bradford. So Anne, over to you to talk about how GPs are faring at the moment.
Thanks, and thanks for asking me to talk. And I'm delighted to hear some of those issues that Richard's talking about, and certainly the RSE in school is such an important point. So being a GP is fairly mind-blowing at the moment. I'm sure it's obvious that I've been a GP for a long time, but we have had to learn an awful lot new skills over the last year, and it's mainly like being a call operator. Many days spending a long time on the phone and trying to work out who I need to see and who can be best managed over the phone, not just for convenience, but to keep everybody safe, keep my staff safe, and keep patients safe out of the clinic where necessary. And we've learned a lot, and a lot of consultations are going very well. And when we come through the pressures of the moment, it's going to be better, because lots of you as people who use our services will know that there are times actually you just want a quick opinion, and you know that can be done over the phone, whereas currently you haven't, or previously you've had to take half a day off to come and wait in our busy surgery, etc., etc. So there's lots of learning to go forward. Women's health, I do have a concern about women's health going forward, because it's often something people don't feel empowered enough to bring us. You know, that thing about, is this normal? Do I want to bother the doctor with it? You know, we as GPs are obviously doing too much COVID stuff, so you don't feel that it might be important enough, whereas obviously it is. So we've got both to learn skills for us as a GP, because previously you might have come with another problem, but while you're here, you might add in, and by the way, my periods are awful. So we've got to work out how we as GPs listen to those conversations better, but we've also got to empower women to come and to say, actually, this is not okay. This is something that's worrying me, and actually I do need some support and help with this. I really like your online work that you've been doing. My only concern about that, and the concern about, you know, all the great information you give out at Endometriosis UK, is you've got to know that's where to look. So as a patient, as a woman, you've got to know that actually I need to think about doing this menstrual diary, or I need to think about, you know, where do you look for your information? So it's got to be very obvious that this is where you go, but actually presenting us as GPs, even a GP who doesn't do much women's health, presenting us with a cyclical pattern, does make it so obvious. That I think most GPs would be able to understand that, but often women, by the time they come, it's very emotional, and it's quite hard to unpick from the consultation which are the bits that are the most important and how you put that together. So I think we've all got a lot to learn going forward, and there's some great opportunities. One last point I will make, and I'm delighted with Richard saying that some GPs are doing better. You just have to remember we're generalists in everything. I have to know something about everything, because you might come to me with anything. It might be mental health, it might be toenail disease, it might be your child's problem, your mother falling. You know, I've got to know something about everything. So it's really hard to keep up to date with everything all of the time, although every year we have to do ongoing learning, and we have to demonstrate that at our appraisal. I will just say a couple of things about what we've been doing, because I think it's really important that Anna and Gemma are the people who need to share their work more than mine. But at the RCGP, the Royal College of GPs, we've been working on a toolkit for GPs. So it's a one-place resource to go to where you can get information. Endo UK, Emma has been very involved with this. Debbie from the FTWW has also been helping us with this, because we wanted to keep it very women focused as well as providing the education GPs need. And we're very excited about a little animation we are about to launch, which we will circulate widely, but it's about how to empower women, but also about GPs using remote consultations. So we're very excited about this, because it's looking forward about how we make sure that whatever care we deliver in the future is right and helps women. One last point, the pathways Richard's talking about from Canterbury, we have developed in our own GP systems. I'm sure all GPs are starting to develop those. They are on our system, so they're on our IT system. And so if you come to me with a dermatology problem, I don't necessarily have to know all that dermatology stuff these days. I can go on to my pathway and work out who needs referring and how I can manage and what I should be prescribing. It's real, and patient information embedded into that. And the women's health pathways are being developed very quickly to support women as well. So it will help us try and keep some knowledge of everything at our fingertips. So there's exciting things going on in primary care, but right now the pressures on us are around COVID, they are around the cancer work, and mental health is just unbelievable. I've never ever dealt with the amount of mental health concerns that I'm dealing with at the moment. So that's a little bit about GP. Emma, back to you.
Anne, thank you very much. And it's really good to hear what is happening, even though it's difficult times. And I think you're absolutely right, is one of the big challenges we have with endometriosis is no one's heard of it. It's not easy to pronounce. And so how do you look for help if you don't know? But what I'll do is, if I can hand over to Anna, and Anna has endometriosis, is going to tell us a bit about her experience. Thank you, Anna.
Hi, thanks for having me on. So I live near Wrexham in North Wales, and I'm 27 years old. I've had 12 operations now for endometriosis. It's left me with a permanent ileostomy bag and an indwelling catheter that I've had for over 2 years now, due to the damage the disease has done to my bowel and my bladder. I didn't have the easiest of rides when it comes to diagnosis. So I was back and forth to the GP from a very young age. So I started my periods at 11. They became debilitating when I was 14. I was missing a lot of school, and I was told constantly that it was just women's problems. I needed to get used to it. And that is quite damaging, because you'll then look to yourself as if, am I going crazy? Is there actually something wrong with me? And when I turned 16, I was finally referred to a gynaecologist, and she did a laparoscopy and said, no, there's nothing wrong, you're absolutely fine. And then 4 months later, I ended up having an emergency appendectomy, and the general surgeon said he could see endometriosis surrounding my appendix. And he said, you've definitely got endometriosis, but it'll have to be a gynaecologist that operates on you. So referred me back to the same gynae, and she refused to agree with his findings. And I was lucky enough that my dad had private healthcare, so I went to an endometriosis specialist called Mr. Christopher Mann in Birmingham, and he diagnosed me. I was treated with him for 3 years until my insurance wouldn't pay any longer, because they listed endometriosis as chronic. That was when I used to be based in Mid Wales, so that's where I grew up. I grew up in a little village called Aberystwyth. It's about 40 minutes from Aberystwyth, so it's in the middle of nowhere. My experience with GPs is that they had no kind of experience with the disease or the condition at that time. So we're talking obviously 15 years ago, when things started going wrong. And my mum was a mental health nurse, so she knew there was something not right, but obviously couldn't do too much to help me because it wasn't her area. And it wasn't until I went privately that I was really taken seriously, because obviously I was then diagnosed with the disease. And it has been a really tough ride ever since. I've got stage 4 and it's very aggressive on my bowel and my bladder. And it's been a huge change and it's life altering. For me, now I'm based in North Wales. Unfortunately, Wrexham is my nearest hospital, and they don't have the specialist care there to deal with my case. So they referred me to Liverpool. So I'm under Arrow Park now. I used to be under Liverpool Women's, but I'm also under the Royal in Liverpool, Broad Green, Walton, all for colorectal urology, pain management. So none of my care is local to me. I have to travel 2 hours each way. You know, it's a 2-hour round trip for me, and well, longer if you take into account having to sit there in appointments and things like that. And I am very grateful for what Liverpool have given me, the care. They've been amazing, but it just shows the lack of care that we have here in North Wales. And it's the same. My GP is amazing in Llangollen. I can't fault her enough. She is amazing, but there is things they can't deal with. So they have to then they would like me then to go to the nearest hospital, which would be Wrexham. But unfortunately, then Wrexham just send me on to Liverpool. They won't actually deal with my case in Wrexham. So I think there's a huge lack of care for women's health in North Wales, especially. And I hope that changes. I've got a 5-year-old daughter, which I'm very lucky to have. I just hope if she ever has to suffer with this disease by the time she's at the age that she needs to be seen, that it's a much more streamlined, easier way to be heard, because over the years I've been made to feel as if it was all in my head and not listened to. And then when I was finally diagnosed, it was a relief, but at the same time, I'd just been diagnosed with an incurable condition that I had no idea, I'd never heard about. So I think coming back to discussing it in schools and teaching it in schools is a huge resource for boys and girls, because they do need to know about the condition, because there will be someone throughout their life, whether it's the sister, auntie, mother, friend, that they will know that suffers with this condition, and people need to know the severity of it, because I think it's misunderstood as it's just your periods, it's just a painful period, when this has been a whole body disease for me. I've got 2 bags because of the disease and 2 failing organs at 27. So it's massively misunderstood, and I think there is a lot of work to be done, but I think we are in the right kind of way. We're getting there, but I feel it's amazing to hear about South Wales and what they're putting together. I just hope North Wales catch up, because for me, I have had a bad experience with North and Mid Wales, where the care, they can't deal with the complexity of my condition. Back to you, Emma.
Anna, thank you for sharing that with us. It's a difficult story, I think, to hear, let alone have experienced, and I think shows exactly why we need to do more, and to do all the things you say. Thank you for that, Anna. Gemma, can I ask you if you'd like to share your story as well?
Hi, thank you for letting me be here tonight. I live in Wrexham also. I'm 34 years old. So I had symptoms from 13 when I first started my periods, and was just kind of told by the doctors that it was normal. It was just heavy, painful periods, and I was just put on the contraceptive pill back to back, as a way of managing it. There was no real sort of exploration about that. Now, This was ongoing for a long time. Similar to Anna, I missed a lot of time off school. And the thing with endometriosis is, depending on where it's located in your body, it can affect you differently as well. So you get a lot of various symptoms, and for me, I would get severe vomiting and sickness that accompanied the pain. And I found that when I was trying to access medical support for that, because this could go on for well over a week to the point where I was dehydrating, was that a lot of the medical professionals were more focused on the other symptoms that I was experiencing. So endometriosis can also mask itself depending on how it presents. So that was my barrier, really, that I was finding that I was getting fobbed off a lot. Also, it was getting insinuated with me that it was mental health. So this went on and on for a while. And interestingly, I didn't get diagnosed with endometriosis in Wales. It was when I was in university in Salford that they decided to do the investigation, because I was presenting at hospital all the time with sickness, with extreme pain. And that's when I got my diagnosis, the day after I graduated. So it was good to find out what was going on with me. However, they said they couldn't do any treatment in terms of the option then they talked about was obliteration, because they said it was too extensive and it would damage my bowel. So I was put on a medical menopause, and I think that was for 3 months, and then they put me on the depot injection for the next 7 years, just as a way of managing it. And that in itself came with its own challenges. However, I was just extremely relieved to just be able to have some sort of function in life. It was the next challenge I faced was when I wanted to try and start for a family. Luckily, by this point, I had been told about the fair treatment of women in Wales they've been supporting me for over 6 years now, maybe a bit longer. So when it came to starting a family and I came off all the contraceptive, the depot and things, that's when I found my endometriosis came back. Gosh, it came back so much worse. And with each month, I felt like it was becoming more and more damaging to my body. So I didn't know anything about excision surgery. I didn't know anything about where to get help. And it was the Fair Treatment of Women in Wales who told me about Arrow Park and these specialist centres. So my next step was going to the GP. Again, I faced many difficulties with that, even though the Fair Treatment of Women in Wales supported me with all the documentation, how to go about trying to navigate that pathway from Wales to England. I ended up paying privately to get a referral to Arrow Park, because for me, it was just becoming so debilitating. I couldn't work. I was at risk of losing my job, so my finances were affected. I just wasn't really having a life. I think I had a few good days out of a month, because having a week worth of periods with that pain and that amount of sickness, I could be in hospital for a couple of weeks at a time each month, and then I was wiped out for a couple of weeks. So it really was a difficult way to live, and then trying to fight to get that support from a specialist centre was tiring too. So from that private referral, I was able to access support from Arrow Park, and I've had 2 excision surgeries with them, and I've also undergone fertility treatment with Shrewsbury Hospital. So yeah, even then when I was experiencing my endometriosis symptoms whilst waiting for fertility treatment, one of the things that I found incredibly challenging is each time I was admitted to hospital with dehydration and severe pain, because that's how it manifests for me, is that some of the comments I was getting from consultant gynecologists, from other healthcare professionals in the hospital, saying things to me like, if you just get pregnant, once you have a baby, this will all go away. Which is just like the most devastating thing to hear when you really want a baby and you can't have one because of your endometriosis. And yeah, at one point they were going to refer me to a mental health team because they thought I was just severely depressed and I didn't want to leave the hospital. And yeah, some of the comments were just so damaging. I work in mental health, so I feel I'm well resourced to be aware of my own mental health. So yeah, to be treated in that way. And it was just a case of managing my symptoms and they'd send me off home. There was no real sort of, like say, treatment plan or continuation of support or follow-up. So I do feel there's still some way to go. And that was only a couple of years ago. Even with all the campaigning and all the awareness that we're seeing now, there's still some misinformation out there, and yeah, it can be difficult to feel so misunderstood whilst you're trying to get through so many barriers with your own health, because it really does affect every area of your life. So yeah, that's my story. Thank you.
Gemma, thank you for sharing that with us. And again, it's a hard story to hear, let alone have to obviously live through that. And I think shows why we do need to do more. You're absolutely right. We've got a lot more to do going forward. We have got, if it's okay, we've got questions. So we're going to go into questions now. Now I see that Jenny has had to leave us. She had a vote that she had to go to, Jenny Rathbone. But when she comes back, we will put some questions to her. But I'm going to flag Richard and possibly Liz for the first one. We're having a lot of questions here around the difficulty, or I should say impossibility, of people in other parts of Wales getting a referral to the specialist centre, and even being told it's around funding, and actually sometimes being told it's specifically about funding. So these are people with bowel endometriosis who can't get referrals. Is there anything, Liz or Richard, you can say about that? You've already touched on the funding issue.
I think if you read the NICE guidelines, then I think you can approach whoever your consultant is if you're out of area and get their support to refer you. Some GPs are quite good at it, but it's just a matter of persevering. I think we would recommend that you get political support if you're really not getting anywhere with your referral. And unfortunately, we have no power over that, do we, Richard? Of the acceptance of referrals. That's done before we get to the patient. So we don't have any say on that really, but it's, sorry, but it's something that we'd hope to improve, and sometimes it works, sometimes it doesn't, but people just have to be persistent.
Yeah.
If you live in Cardiff, it's slightly easier because sometimes they can approach through self-referral clinic, you know, so we can give them more help that way. But it's the people who live out of area, we don't have much. But I am really, really hopeful that the hope is that when we develop these endometriosis nurses, I know 2 of them are watching tonight, is that we will develop a similar service, or if not identical service, that's all using the same portfolio throughout Wales, so that we're delivering the same service, so everybody has access to the same tools and the same needs and the same help that they have if they lived in Cardiff.
And I think, yeah, and I think that point, Liz, about for those of you who have got all the way through and been told by a certain Mr. Davis that they just can't be accepted, I would echo Liz's point about speaking to your members of the Senedd about getting support going forward. Richard, have you got anything?
Can I come in there? I think the endometriosis service is broken, and I think it's kind of really at such a place where it almost has to fail to be fixed. And I think the more that Mr. Davis rejects referrals, the more political pressure that women can put on to get things sorted. I know it's very frustrating, but we have had ladies who've gone through and got permission from the chief executive of Swansea Bay Health Board to get referred to Cardiff. The other bit of development that some of you may not be aware of is that Swansea are now a provisional endometriosis centre. They have all of the necessary to be recognised by the British Society for Gynaecologist. So there may be an argument that Swansea ought to be able to look after its own women with complex endometriosis, because they've got the necessary bowel surgeon working with the gynaecologists there to take things forward. The requirements to be an endometriosis centre are that you have an endometriosis nurse practitioner with a certain amount of time dedicated to endo care, that you have a multidisciplinary team, that you work with a named urologist, named colorectal surgeon, named pain management specialist anaesthetist, and you have an MDT. I'm really optimistic that Swansea will be able to get full endometriosis recognition, which would come in 2022. Then, in theory, there shouldn't be any need for any patients to come to Cardiff from the Swansea Bay area. What will happen with West Wales? I don't know. They have a tradition of referring past Swansea to Cardiff in the past, but we'll see. We get a lot of referrals from Cwmtaf, and I've been doing some outreach operating with colleagues in Cwmtaf. Hopefully, if they identify a small number of champions, we ought to be able to get their level of skill improved so that more less complex endo can be done locally than needs to go to a centre, because really you don't want to go to travel miles to have your operation. You want to be managed locally, properly and well.
Yeah. Thank you, Richard.
Can I just add?
Yes, Alice.
I think with the endometriosis nurses, I think what Richard has touched on is that we are going to have a named consultant. I think that is so important. But the other thing we really need, and we need, a pity Jenny's not here, we need the funding for, which we did request for, is the pelvic physiotherapist. Every day I realise this is more and more essential. And I think if we had a pelvic physiotherapist working actively alongside everybody else, seeing patients regularly, it would be a great improvement in the patient management.
Yeah, I always find it's interesting, isn't it? Is that I can injure my knee doing something probably very silly.
You see it straight away.
Get physio, but if it's to do with my vagina or womb, apparently that doesn't matter whatsoever.
Yeah, but there are physiotherapists out there who are really keen. I mean, I've been speaking to loads all through Wales, and they are so keen. They are so dynamic. They're proactive, and they want to deliver a service for the women with endometriosis.
Yeah. Thank you, Liz. Now, Jenny, thank you for coming back in those times. We were just answering that we've had quite a lot of questions of people who've been referred to the Cardiff Centre, but they've been told by the managers that there's no funding and that they can't go. And so I'm afraid one of our recommendations is that to contact their members of the Senate to see if they can get support going forward, because if they've been diagnosed as recommend needing to go to a specialist centre and then they're being told by someone that a funding issue means they can't go to a different area, I think that's sort of quite serious in terms of things going forward.
Yeah, obviously there is a committee that looks at extra contractual referrals, but that takes a long time and we really need to speed this up now. I'm afraid I'm only with you for about 10 minutes because the vote actually isn't taking place for another 10 minutes. But yes, speak to your member of the Senate, but I'm afraid we drop off the end on April the 6th, and so you won't have any Senate members for a month because the election's on May the 6th. But it doesn't stop you agitating with your candidate to make sure you get some decent commitments out of people from all parties.
That's a very good point, Jenny, and do if people would like to contact us and let us know where that's happened, we'll work with FTWW, and also we will look into whether we can support people by doing, you can do these template letters to go to members of Parliament and asking people what they will do about that, and to the members of the Senate as well. So thank you for that. I've just had a question here. I'm going to have to say this out. Is when will the brilliant, basically that Lizzie is brilliant, but are you going to retire and will you be replaced? So that's another one we need to make sure we get done as well going forward.
I'm semi-retired at the minute, but it doesn't feel like I'm working more than ever. I am very passionate about training all these people who really, we've got a lot of people who actually want to do the job. So most places have employed a full-time person. I had hoped that they would go for part-time, but again, I think one person and 37.5 hours is not going to be enough, particularly for some of the more rural areas. We really do need to get into the community, because they haven't got the option of going to hospital in some parts of Wales. So, we need more than we've been given. But I think it will come, and we just need to prove the benefit of what we have. I'm not going anywhere at the minute. I've got at least another year. So, and the people that are coming in are good.
Can I come back on that for a moment?
Of course, Richard.
Can I make a comment? Basically, this girl that you're looking at now on your screens needs to have her knowledge transferred to her replacement So we need to appoint her replacement before she retires, and we need to pass her knowledge to all of the new endo nurse practitioners that are being appointed at the moment. And that needs to be facilitated by a big kick up the backside to Cardiff and Vale. Thank you.
Thank you, Richard. We will take that up, metaphorically.
Yeah, we've only been asking for about 6 years.
Moving on, if I may, and this is what I'm hoping maybe Jenny can help us with, is we've talked about mental health, but the pandemic has had a huge impact, we know, on mental health. And the All-Party Parliamentary Group report on endometriosis identified, this closed in March last year, so before COVID, that 95% of people with endometriosis said it had affected their well-being, and 81% had affected their mental health. So I suppose really I'm wondering what is it that can be done to ensure that those with endometriosis can get access to mental health support. I don't know, Jenny, if you've got any overall thoughts on that or not.
Well, we've got a mental health pandemic going on. As Anne said, you know, that this is worse than anybody's ever known it. We've got a climate crisis as well, and disruption from Brexit. So, you know, it's huge. But we're going to have to tackle mental health at the you know, anxiety and depression level with counsellors immediately, and then, you know, filter out the people who actually need mental health specialist appointments, because we simply haven't got enough people to deal with all of them being seen by specialists. So we've got huge challenges, but there are noticeable signs that they are integrating health and social care with other voluntary organisations as well, because they have to. A lot of change has happened as a result of the pandemic.
Thank you, Jenny.
Emma, could
Yes.
I just
Yes.
come on the mental health side, just because I had a conversation with my mum about this. She's a mental health nurse in Wales for 40 years, and I've suffered with endometriosis, diagnosed for over 10 years now, and not once have I ever been offered support with mental health. And I think that's one that is completely missed with endometriosis patients, especially when they're dealing with chronic pain on a daily basis. It is debilitating, not just physically, it's mentally as well, and it can really torture you and destroy you. And I think there's a massive gap where, yes, I know the care with endometriosis, it's a minefield anyway, but I think there needs to be something where we look that we support women with endometriosis with mental health, because if it wasn't for my supportive family, I wouldn't have got through what I've gone through in the past 10 years. It's been very, very difficult, and not everybody has that support. And to be able to access that, I've been crying my eyes out to GPs before now, and I've just been offered antidepressants and that's it. So I think we really do need some sort of commitment when it comes to bettering the endometriosis care, not just physically, but also supporting them mentally.
Yeah, I completely agree with that. Thank you, Anna. And I don't know, Anne, if you had any thoughts on how people can maybe access mental health support via their GPs. And I suppose a second question leading on after that is, and how can we improve awareness and knowledge among healthcare professionals about endometriosis?
I absolutely agree with all these comments, and there's a real lack of recognition of the psychological impact and the social impact of conditions like endometriosis. You know, because I understand, because I've spent so long listening to Emma tell me about endometriosis and the impact, you know, I've done some podcasts with patients that you really understand this huge problem with schooling and education, and it's a time when women are young, and it does have the longer term impact, just as you've described. So part of the work we've been trying to do with the RCGP is really to try and get people to understand this pressure and this psychological impact of something like endometriosis. And I've seen some of the chat talking about, you know, chronic disease and disability, and it's exactly how you know, we're very good at chronic disease in primary care. We spend half our life doing diabetes and cardiovascular disease, but for me, why doesn't endometriosis sit up with that sort of mindset? Because as you know, the clever surgeons can do clever surgery, but it is something that at the end of the day is going to be living with you, or certainly till you, well, it will be living with you. So what can you do? Firstly, I think having the likes of an endo nurse there is absolutely fantastic, because you know, Lizzie and her team really do understand the, you know, to deliver that care. Nurses are fantastic because they really understand the woman's issues and are much better than us as clinicians at trying to put the whole picture together. So having better access to someone like Lizzie, and I agree with everyone's comment, Lizzie certainly shouldn't be allowed to leave, but having access to someone like Lizzie where you feel much more able to talk about these very personal issues, maybe pain during sex, you know, which you feel like, oh, I can't talk to the GP because they're far too busy. Those sort of, you know, like holistic care, and I think that will be one way to help with all of this. Endo UK, fantastic support, and again, people, you know, we are going to have to look at how we restructure health system, because we can't keep affording to use me as a GP to do what the voluntary sector, the charitable sector, you know, the multidisciplinary team can do. And patients have got to understand that, and we as healthcare professionals have to understand that. It's about using the team in the right place, right time. I don't think this is answering the question, but if you have mental health concerns, you know, it is certainly the time to go to see a GP or contact your GP for referral to mental health services, because it's what we're doing all the time. You know, we are really understanding the anxiety and the depression about, you know, living with a chronic problem at a time when it's really difficult to with this lockdown stress. You know, we all know that and we've got better pathways, and we're using the voluntary sector more, and we're using counselling services more, and we've had to understand who's out there, because and using online resources more. And we've had to get out there and understand, because we just can't keep sending everybody to mental health services, or else no one's ever going to get seen. But using Lizzie's team, and certainly both of you two, you know, Anna and Gemma, you've got severe problems, so you really should be in touch with somebody as specialist as Lizzie. I think, I can't remember what the other question was. I think I might have covered it, Emma.
Yeah, okay, that's good. Liz has her hand up, so let's go.
I just want to say that there's no doubt that there's a higher suicide rate than average with people who've got chronic symptoms of endometriosis, and there is mental health issues. But I worry a lot, because I come across people all the time, and with the self-referral clinic, which I'm hoping everyone else is going to develop, I spend an hour with these women, and there's a definite, there's only a small group that have, I would call, real mental health issues. Most of them, it's just they're completely chronically depressed because they're unable to do what they want to do, because they can't control the symptoms. So I worry all the time about people just being put on the mental health and then put on antidepressants, which is not what they need. What they actually need is their symptoms to be resolved, and to be able to manage their own symptoms better and get a better outcome and a better quality of life. So just going down the mental health path is not enough. And for many, I don't think it's actually, that's not going to solve the issue. It just may create further issues. And so I always worry about going down that too quickly. That's all.
Thank you. And I think the other thing for me as well is, and Anna and Gemma both talked about this much more eloquently than I will, which is there's such a long diagnosis when you're being told in your head, and you're just making it up, and you should go on with it. I mean,
yes, so by improving all those things, then we can reduce the impact on mental health. There's no doubt there's impact on mental health, but they're not mentally ill. Yeah, they have things which are causing it, which need to be resolved.
Absolutely. And so let's get that diagnosis time down. And again, Jenny, we're keen to work with the Senate to ensure there's commitment to drive down diagnosis time, which is great. Richard, one for you here. you've been talking about complex surgery, and we've been talking about surgery, about who goes to the specialist centre. So the question was asked is, who decides what is complex surgery and what is not? So if someone, how is it decided if someone can be referred for complex surgery?
I think that's interesting. I don't know how my consultant colleague, clinical director, decides who is allowed to come to join our team and who isn't. To my mind, if you've got endometriosis involving bladder, bowel, ureter, that's not secondary care gynecology, and it should go to a BSG endometriosis centre or a provisional BSG endometriosis centre, because that's where the team has been put together to try and solve these problems. Now, there is talk in the BSG that we should be even having super specialist centres to look at things like thoracic endometriosis, so that, you know, where do you go if you need what's called a VATS procedure to look inside your pleural space and see if you've got endometriosis? Well, one has been done in Cardiff, one. And there are 3 other women, I think, on the waiting list. So this is relatively new. Bristol has been doing some, but it's probably not every endometriosis centre needs to do that highly specialist work. But to manage the bowel properly, to manage the bladder properly, to manage the ureter properly, that should be normal. To manage the diaphragm properly should be normal too in an endometriosis centre.
Thank you, Richard. And I think for me, I can sort of see it in the, if we fast forward 10 years, diagnosis times come down. Every gynae department has somebody with a special interest and training in endometriosis, and we have these super centres that do the bowel, etc. And then we have, if you like, we make sure we do fertility for thoracic. I suppose the thing for me is, how do we get there over the next 10 years and support people getting there? So I think that's
no, even better than that. Andrew Horn's new medicine will be available, and it'll help treat endometriosis symptoms without hormones, and everybody will be happy.
I have to put a health warning that very early stages in research at the moment. I don't know if everyone's heard about this. This is some work they're doing in Edinburgh around repurposing a drug. So do look out for that one. I'd like to, there's a question, someone's raised a point here that they had, they think, a unique experience. They, for the first time they went to the GP's diagnosis was under a year. Her GP was very aware of endometriosis, listened, referred correctly. And so I suppose the question is, like, you know, and I suppose, why doesn't that happen every time? And is there training in place to ensure GPs are specifically educated about women's health issues?
So every GP to qualify as a GP has to do generalist training. So they have to do something, they have to know something about everything and pass an exam where they could be asked about anything. So at basic GP level, yes, women's health is on the curriculum, and as is everything else. Ongoing, every year we have to demonstrate that we have done learning in areas that we keep us broad. So at my appraisal, I have to demonstrate, even though I am a women's health GP, I have to demonstrate that I've done learning on respiratory disease, on diabetes, on pediatrics, so that I can demonstrate that I still have a generalist knowledge and I'm still safe to practice, as well as continuing to demonstrate that I've done enhanced stuff on general practice on women's health. We also have to do all the mandatory training, such as safeguarding and CPR, you know, life-saving stuff, and endless of that. So it's not mandated that every GP has to do women's health. It is part of what you recognise in yourself as a GP, and you recognise that because you see patients who come in with something that you might not have kept up to date about. So you will then either go away and try and learn something about that because that's what you're in, because that's what GPs do, or you put it down in your appraisal as a learning need for the following year, and then you have to demonstrate that. So that's how it works. But just keeping up to date with everything is we just need the resources to hand, which is what we've been trying to do through the RCGP work that I've been doing with you, Emma.
Thank you, Anne. And I think Anna and Gemma, at various points, you both said that you had some good experiences with GPs. Do you think they're, not all of them, but do you think there's some any sort of tips of, if you like, working with GPs, anything that you found helpful?
For me, I found you've got to be completely honest with your GP, and I know it can be sometimes embarrassing to talk about subjects, especially one was raised earlier that you get a lot of pain during sex when you've got endometriosis, things like that, which is quite a big symptom, especially of rectovaginal endometriosis. So you need to be very open with them. I have got a good GP now. She is amazing, and I hope she never retires because I'll cry. But she also had a background in women's health, so she'd worked in a women's hospital before. So I think that I'm just very lucky that I found her. And it's just over the years where I've had to see other GPs in the surgery, they've got to know me because I'm there so often, unfortunately, having checkups and things because of my catheter or my stoma, various reasons. So they've got to know my history, which is really good that they take the time to kind of know more about you. But I don't know whether it would, I've thought about this for many years about whether it would help GPs to speak to endometriosis patients to understand what it's like, because I know GPs have got so much on their plate anyway. It's very similar when it comes to like teachers, with us saying teachers need to be aware of young girls suffering, but then you could argue that with every condition, so it's a hard one to balance. There are good GPs out there, but I think there's some that just don't quite understand the disease and the severity of it, and unfortunately we do still get comments like just have a baby or just have a hysterectomy, and I'm proof that having a baby, I'm 10 times worse after I had my daughter than I was before. So that just proves that pregnancy is definitely not a cure for endometriosis, and it's outdated knowledge, I think.
I think that's a polite way of putting it, Anna. Yes.
Yeah.
I don't know if there's anything you wanted to add at this point.
Yeah, I think I agree with Anna. It's a real mixed bag in terms of responses I've received from GPs. I've had some that have been fairly knowledgeable. I've had some that have been incredibly dismissive. I think from my experience is that because I have been dismissed so often, it's built up a mistrust in accessing GP services, and then you do have this sort of learned helplessness where you just think, well, no one's going to listen, no one's going to believe me. That's been my sort of barrier as well. And then just having that confidence to communicate and also to challenge them sometimes and say, actually, no, this doesn't feel normal, or no, I don't want to go on another cycle of contraception because it's affecting my mental health. Them to have that knowledge, or even ask them questions, explore your options, you really do notice a difference in those that maybe have that bit more of an awareness about women's health, because they will perhaps be a little bit more curious about what's going on, and then you can open up. But even just things like someone just taking the time to listen, having a bit of empathy and warmth towards your situation and hearing what you've got to say, I found that really helped me. Because as soon as I felt like I was being shut down, a barrier went up. One doctor even told me to Google it, to go and Google something. I think it was in terms of mental health support. Because I was, experiencing some difficulties with my well-being. And I just thought, wow, to be told to make this effort to come to an appointment to build up that confidence, knowing I've been shot down so many times, and then to be told just to go and sort it out yourself, that is a barrier for me. So even just someone listening, and even if they don't know the answer, is helping you or guiding you or signposting you to somewhere who might be able to help you, that I think that was something that I would have found helpful. So yeah, like Anna said, there's some really good GPs out there. However, there's been some experiences that have been, I think, detrimental to me wanting to access support again. And I do see that with a lot of people now still.
Yeah, thank you, Gemma. Yeah, I think that's right. And I think one of the things that knowing Anna's taught me that if you're not getting where you want to with your GP, speak to the receptionist or practice manager and ask if anyone specialises in women's health. Because I think remember Anne, you once said to me, I don't really do men's bits that well. You know, it's that sort of thing, isn't it? Is find someone who can help you. So so do ask about who you can see. Liz has her hand up.
Right, thanks for the best way. There is a movement in Wales and many of the health boards that they're going to specialise GPs into, so they're going to link GP practices and then develop special interests in different GP practices. And I think that will be to our benefit for our patients. It may mean you have to travel around locally a little bit further, but you will get to a specialist GP who has a special interest. And I think they've been doing it in Cardiff now, and it is beneficial. The other thing I'll say is that, and I will encourage the new nurses to do it, is that I know which GP I've spoken to. So many of the GP practices in Cardiff have invited me along to give presentations, and I always know which ones have been me because I get a lot more referrals to me once I've been to a clinic. So I think this is really important, is ongoing education and support. And the GPs have a really rough time. You know, my sister's a GP, so I have a lot of sympathy for her. And they have to deal with so many things. Every patient will be completely different. But it is up to us as well as the secondary to go out and regularly give support and give encouragement and keep them up to date as well to enable their education. We can't leave it up to just themselves.
Thank you. Thank you. Now we have been joined by a new panel member, Jason Kasraie, is very kindly joining us at the moment, who is a fertility expert, I know, among other things. We've had a few questions around fertility, so I thought it might be a good time to go on to that. And one of the sort of more general questions, if you like, is what people are finding, Jason, is that they find it very difficult to access fertility services. So even though they've diagnosed with endometriosis, so it should be recognised, they're, if you like, put on the normal cycle, if you like, of, oh, wait a couple of years, or they can't access it. So I suppose maybe could you start by saying, have you got any top tips about how to get referred to a fertility service at all?
Yes, hi. Thanks for the invite. Sorry I'm late. I was in a meeting prior to this as well. Can you hear me okay?
Yeah.
Okay, good. I think it's persistence, really. I think you just have to persist, and you almost have to get to the stage where you're telling your GP that you should be referred. Sometimes it helps, I think, to contact the specialist centre directly, because they're more than happy to give advice. And you know, I've been in this situation before where you've advised a patient to go to the GP and say, "Can I please be referred?" and say that the specialist centre has asked for the referral, and that will quite often, you know, convince action to be taken. But I think it is sheer persistence, and the problem I feel is that for the majority of patients who have infertility, you know, a 2-year wait is probably a good thing if they're young enough, because a lot of them will conceive whilst they're waiting. You know, this is it's not necessarily a bad thing. We want to avoid treatment if at all possible, but certainly if you have a pre-existing condition and a diagnosis, then you should really get an earlier referral so that you can start investigations and treatment earlier.
Thank you, Jason. And you make a really good point there, actually, because I think we quite often do talk about fertility and endometriosis, but of course, many people with endometriosis will be able to get pregnant naturally, won't they?
Yeah.
Yeah. So thank you for that one. Sorry, I'm just trying to read questions that keep coming in. Anna, you've got your hand up and Richard has. Should we go to Anna first and then Richard, if that's okay?
Just going into Jason saying about fertility, I was referred to Liverpool Women's for fertility treatment because I'd been trying for just over a year and I was diagnosed with endometriosis. So I had various tests done in Liverpool Women's, and then my husband was fine and it was me that was the issue, as they like to put it. But they then put me forward for IVF, and I actually caught 2 weeks before I was due to start my IVF treatment. So if you're saying the longer wait for the younger people, it does actually, I've come across that a lot, especially in the endometriosis community, when they've then been referred for fertility treatment, then that's when it's happened. Not always, but that was the case for me. But again, I had to access fertility treatment in England, not Wales.
Thank you. Richard, did you want to say something?
Sorry, unmute myself. The Fertility Centre, Wales Fertility Institute, has an accelerated pathway for women who have severe endometriosis. So they will see you and treat you within a couple of months. So the best time to conceive after really good, thorough excisional surgery for your endometriosis is within the first year. Many couples who've got normal sperm counts and patent tubes and are ovulating will want to try do it naturally for a reasonable period of time, but there is a mechanism whereby you can be referred. And I've got 1 or 2 ladies now who are in parking waiting for their IVF to be woken up when they're about 7 or 8 months into trying naturally after endometriosis surgery.
Sorry, I was on mute then, wasn't I? Sorry. If we can stick maybe with fertility just for a moment, is one of the questions that we have been asked is that people with who maybe have their various treatments due to cancer, which might be the same treatment outcomes as with endometriosis in certain cases, people with cancer can have access to fertility preservation like egg freezing, but there doesn't seem to be support for fertility preservation around endometriosis. So I suppose are people with endometriosis able to access fertility support, or is there a different playing field for different conditions? Jason, do you want to maybe, I don't know, kick that one off?
Yeah, so there is a pathway for cancer patients, a fertility preservation pathway, but there's also a very similar pathway for women who are in danger of losing their fertility. So for example, if you were going to have a hysterectomy, if you're going to have your ovaries removed, anything like that, and I'm conscious some of these things might happen in very severe cases of endometriosis. So it's the pathway is kind of there. Sometimes we will have to apply through what's called a special funding request to the relevant CCG or to WISC if it's Wales, but they do tend to be very good with funding fertility preservation, and as long as a clinician classes it as a preservation case, they will usually fund.
Thank you, Jason. So that's worth knowing. I think we might be coming back to you to get some Q&As answers on our website afterwards for that. So that's because it's one of the common questions we do get. And one of the questions I might actually kick off answering myself is we've had a question about why isn't endometriosis classed as a disability? And so one of the things is the way that disability tends to be dealt with in the UK is that basically, if you are disabled by something, you are disabled. There's very few actual conditions that are labelled as being a disability in its own right. And the reason for this is there's a lot of conditions, and in fact, endometriosis or diabetes, sometimes arthritis, where it can be a spectrum. So some people can have endometriosis and have mild symptoms, or in fact, they might not know, they have endometriosis unless something else happens. That's not, it's not common, but it does happen. And at the other end of the scale, we've heard from Anna and Gemma, and you'll have your own stories. But in theory, certainly it should be that if you are disabled by your condition, then it does count as a disability. So it shouldn't matter whether it's listed or not. I think there's hardly any conditions listed. There's a handful that are. So I think that what I'd say is that if you are having problems, do push. I think everyone's heard and read on the news just how difficult it can be accessing disability payments for anybody whatsoever. So do persevere with that one. Richard, have you got your hand up because you want to answer something on that, or you've got a legacy hand, one of our new phrases? Okay, cool. Yeah, Liz.
Say on that we do get lots of requests, and it's very difficult because the questions that they ask are things you observe for day-to-day living. Now we see somebody maybe once or twice a year, so it's very difficult to make the assessment by looking at what their symptoms and what medication they're on, etc. So it is very much, but there is an inequality depending on where you live and who you happen to see that day. I think it doesn't seem to me to be very fair distribution of outcome, people with similar impact on their system, because as you quite rightly say, somebody can have the most severe endo, but they haven't got, their symptoms are minimal, and other people are severely impacted. But there doesn't seem to me that there's a great fairness throughout Wales of how people are treated. Well, it's probably the whole of the UK as well, but definitely in Wales, it depends where you live and who's on the meeting when you get there.
Absolutely.
And we need to have more equality and fairness about that.
Yeah, brilliant, good point. Now, just before I bring Gemma in, one thing I should have said is that the Equalities Act does allow for what they call intermittent conditions. So if anyone says, oh, well, your endometriosis affects you worse at different times, that is allowed for as well. Gemma, were you going to add something?
Yeah, in terms of the disability discussion, I just wanted to put out there as well, not just the financial aspect, but in terms of trying to work and have time off work. Like I've been through so many sort of policies and procedures and managing attendance meetings with my employer and nearly lost many jobs because of my condition. Now, a lot of the time I was still able to work and carry out my work doing it. But that's something that I faced as an issue as well, is just trying to stay employed with this condition too, and then know that I wouldn't be able to, get any support. Luckily, like I say, the Fair Treatment of Women in Wales have been really helpful with me and advising me on that. But that's been so difficult too.
Thank you, Gemma. And I know, and it's one of the most common issues we get raised is about how to be managed at work, if you like, because people don't understand. And that's why we launched last year endometriosis friendly employer scheme, which we piloted with Standard Life, and we now have about 50 or 60 people involved in that, including a whole range of different organisations, because I think that where we see so much difference and report so much difference is where there's a supportive organisation that gets endometriosis. Even little things like the managers know what it is, or there's at least an information sheet and someone they can talk to, makes so much difference. And in fact, so we're going to be promoting that. Richard, I'm going to come back to you with a question, and you've already touched on this, but we've got a few people, and we can't talk about any individual cases here, but a few people who were told that they would be needing surgery within 3 months, but they're now told there's no space for them and they're going to go over that. I think we all recognise COVID, but we also recognise that difficult situation. Is there any answer to that? What can people do?
Basically, the prioritization is set down, and can you hear me all right? Yeah. The prioritization 1, 2, 3, 4A and 4B. 4A is that can reasonably wait 6 months. 4B is that can be reasonably wait longer than 6 months. 3 should be operated on, I think, within 3 months, which is what a lot of our women, we are categorizing them as that, because they've got chronic debilitating pain, and that to me counts for a heck of a lot in terms of how soon they should be operated on. The problem is that there are more people being categorized as 3 by our team than there is capacity allocated to our team at the moment for surgery. We've probably got about 20% of our pre-COVID capacity open for operating at the moment. And up until the end of March, that's been relying on benign gynecology operating 1 day a week at Spire. So before COVID, I'll give you an example. I had 1.5 operating days per fortnight. Since March, I had 2 operating days, end of June, beginning of July. And if I hadn't picked up 2 extra days by chance, I would have had 1 operating day before Christmas, and I've had 1 operating day this year. So you can see how pitiful that is. And I don't know quite how the health board has allocated the theatre capacity that's available. We can understand that theatre capacity is reduced because they took the recovery nurses to look after intensive care patients for COVID. But at the moment, there are only 6 intensive care patients with COVID in our intensive care unit, because we get bulletins, on an almost daily basis. So that need has reduced. And I don't know quite why we have been not able to open more theatres. Lots of staff off isolating, and that impacts on your ability to have normal capacity. But I would suggest that benign gynecology has been a victim in the allocation of theatre capacity. I'm not quite sure why, but we're hoping that things are going to improve. There needs to be a significant recovery plan, because there are a lot of ladies who are waiting ridiculous amounts of time for operating. We were told in March, April, May that we couldn't add anybody to the waiting list. True, Liz? Yeah. So that we kept a little list of who we should have added to the waiting list, and we've quietly crept them onto it since then. But it's a big problem, and it's going to need resource and commitment from the staff to be able to do extra. One of the problems, and it's a shame that Jenny isn't there, but one of the problems is that if you work for the NHS and you work part-time, you don't get overtime according to Agenda for Change until you've worked 37.5 hours. So if you're asking a healthcare support worker or a theatre nurse or a ODP to come in on a Saturday or a Sunday and operate, they get paid basic rate. So this is a big problem, and we need to sort it out.
Richard, thank you for that. And
also, we've lost our theatre as well, because of the green zone. Our actual theatre that we use is mothballed. Is mothballed. So we don't actually have our theatre available to us either.
Yeah, thank you for that. And certainly, Richard, we will, and for everyone who's asked questions around that, we will follow that up with Jenny and the other members of the Senate as well going forward. But Anna, you wanted to say something, and we are coming almost up to time. So Anna, I'm going to have yours as the last comment, please.
I'll be quick. I'm just on the back of what Richard was saying. I was in hospital for 8 days 6 weeks ago, and I've been told I need a subtotal colectomy and stoma revision because my stoma has retracted and I've got no function in my large colon. And I was told that would be, I'm on the urgent list, surgical list, and I should be done within 4 weeks. Now we're week 6 and still no surgery. And I speak to my consultant every week. And unfortunately, this is with the Royal in Liverpool. They only get given 1 urgent surgical list a month at the minute. And it's just, unfortunately, it's been affected. COVID's going to have a massive effect. And I hope there's going to be, like Richard was saying, like a recovery plan, because otherwise people are going to be waiting ages and ages. And for me, myself, being told I need this surgery so urgently, and then the weeks tick by. It's really difficult. Yeah, it's really difficult.
Anna, thank you for that. And I think a call for all of us, certainly for Endometriosis UK and other people, that we need to keep shouting and we need to keep pushing and doing what we can, because, you know, endometriosis for too long has been sort of, you know, we haven't got the research into it historically. That doesn't have the theatre time even pre-COVID that it should have done. So we have a job to do. But I do strongly believe that with everybody's voices and working together with FTWW, Fertility Network UK and others, that we can all together make as much noise as possible and try and at least leverage what we can, so that we don't get a situation where endometriosis is forgotten about. I am now 1 minute over time. I do apologise for that. Liz, you've put your hand up. Quick, if you put your mic on, you can have 1 minute.
Right, sorry about that. Just quick, somebody made a comment about scanning, and that's something we've been doing a lot of work on recently, and both for the endo nurses and as part of the BSG endometriosis subcommittee, is we've identified that scanning is a skill which is got to be top priority for the nurses to learn, and the doctors as well, but the nurses to learn, because it really, if you can use it properly, then you can, although not always, but you can definitely enable your planning for surgery.
Brilliant. Now, Richard, you've got your hand up. 1 minute, if you don't mind, because we are over time.
I will take less than a minute. There's a few points that I've been picking up from the Q&A thread. 14-year-olds don't need a laparoscopy, okay? We know that endometriosis can be congenital, and it manifests itself during your teens and 20s. So you can have a negative laparoscopy if you do it too young. What we need for the young women, teenagers who've got severe period problems is good medical management to tide them over until they need a laparoscopy. So definitely, yes, some need a laparoscopy, but the vast majority are not. You know, if we can manage their symptoms and get them well, then that's an outcome that is good. So you don't need to have a label that is definitely, I've got endometriosis. You can have suspected endometriosis and only have a diagnosis based on a scan finding of an endometrioma or a laparoscopy at a later date. It doesn't matter to get it right that early on. The other thing I would say is, do we need to all make a new pathway? Why can't we share things? You know, the stuff that's been done in one health board would equally be applicable to the next one with minor modifications. So please, let's share things. And the other final comment about the Scottish Andrew Horn's drug trials, I've had an email from him today that says at the moment they're only doing trials within Lothian and they're not looking for a wider set of access yet, but I've put Cardiff forward as a centre for when they do. Thank you very much.
Thank you, Richard, and thank you for those points. And certainly we're going to be pushing to see what we can do to leverage some funding so we can get that research continued. I'm going to have to draw this to a close just because we're running over, and I would just like to thank everyone for attending. I'd like to thank all the speakers, Richard, Liz, and Jason, Anna and Gemma. Thank you so much. And Gemma and Anna, thank you for sharing your story so eloquently with us as well. Yeah. And Jason for joining us after a very busy day. I know you've had as well. So I'd just like to say thank you. What we'll be doing is this recording will be available afterwards at some point on the web. We will follow up with the MSP, I was in Scotland the other day. We'll follow up with the members of the Senate about all the points that have raised, and we'll pull out all the questions that we haven't had a chance to answer them all. We will analyse those and make sure that the members of the Senate see those as well. So I'd just like to say a really big thank you for everybody and to all our speakers. And Liz and Richard, I know you'll be missed when you eventually get to retire, but thank you for joining us today, and thank you, Anne, Jason, Anna and Gemma. Thank you very much.
Okay.